And Anne-Marie and Catherine.
Thanks, Carl.
Yeah.
Hi, everybody. Thanks so much for joining us tonight. My name is Anne-Marie Hopkins, and I'm the Director of Operations at Ottawa Inner City Health. I'm joined tonight by Catherine Dallaire, a registered nurse with us at Inner City, who's our head nurse coordinator at our hospice. We're really excited to be here tonight. Like Carl and Val said, if you have any questions, feel free to put them in the chat or ask us at the end. So just a quick housekeeping PowerPoint here. So just our disclosures as presenters. So I, Anne-Marie Hopkins, within my role at Inner City Health, I do research with Massimo Corporation on desaturation events in supportive living housing settings. And Catherine does not have any disclosures to make. We've not received any financial or in-kind support from any nonprofit, and we have no potential conflicts of interest. Just a quick slide here about mitigating potential bias and the learning objectives for tonight. So at the conclusion of this sessions, participants will be able to understand the perspective of providing harm reduction in a palliative care setting, recall and summarize the guiding principles of harm reduction, identify 3 harm reduction programs or services that Inner City Health offers at the Diane Morrison Hospice, and recognize and distinguish structural and systemic barriers faced by individuals who have substance use disorder and or mental health challenges. So we're just going to switch over to our PowerPoint out of this one. Okay, great. So welcome to our presentation. Before we get started, we'd love to get an idea of the different environments that everyone attending is coming from. So we'd love to know what area of work or interest brings you here today: palliative care, substance use, mental health, harm reduction, community health care, hospital, or other. And we'd love for you to let us know in the chat. So we'll give you a moment to fill out that poll. Okay. All right, just give a couple more seconds there for people to respond. Are we able to see the results, Carl, or we get them after?
Yeah, so they'll just come through in a little bit here. It looks like we got about 30% have answered it so far. So I think we could just leave it for a little bit longer here, and then we'll share the results.
There's also quite a few folks that have put their responses in the chat. So we have folks working in long-term care, community pharmacy, home and community care support services, community health, and hospice.
Great. Okay.
And
That's great.
Do you see the results there?
Yeah.
Share them. Okay.
Yeah, that's great. So lots from palliative care. That's wonderful. And so many other settings. So that's great. Cool.
Yeah, it looked like we had about 51% from palliative care, 53% community health care were the big ones, 11% hospital, 2% shelter, 13% in that other category, 2% substance use, 4% mental health, and 4% harm reduction. That's great.
Great. Okay. So a little bit about us. So Ottawa Inner City Health is we're a harm reduction healthcare organization that was founded in 2001. Our Diane Morrison Hospice was actually the first program that we opened. We have many healthcare programs now, and we are much bigger than we were back in 2001. And we have about 14 programs now. So some of those are in shelters and some of those are based in supportive housing programming. So how we operate is we do all of our programs in partnership with other organizations. So for example, our hospice is inside of the Ottawa Mission. So we use their physical space. They provide us support with facilities, and we provide the healthcare staffing, and we run that hospice program within the shelter. And that's a very similar model as many of our other healthcare programs. So the Diane Morrison Hospice was opened in 2001 in response to the HIV/AIDS crisis. It was a tiny little 6-bed unit, and it was opened with the then executive director of the Ottawa Mission and the executive director of Inner City Health. Now we're much bigger. We have 21 beds. 14 of those beds are palliative care beds and 7 are acute care beds. Those 7 acute care beds are really important to our operations. We may have a client who's in a shelter bed or who's in a supportive living bed that might have, a serious illness or an intensive surgery, and they might need just some intensive nursing care. And so we built that into our hospice so that clients could get the care that they needed. So some clients might transfer to a hospice bed, or they might go back to their regular housing or shelter once they recover. I'm going to play a video that was made by the Ottawa Mission. It's a really good visual of what our hospice looks like and kind of the culture that we have there. So I'm going to just open that up now.
Compassion, care, dignity. These are the values, the principles, and the commitments that permeate these walls. Some might see me as a place of darkness or a place of fear. Those who really know me see that I'm a beacon of hope. A place that is free of judgment, a place of comfort, belonging, and unconditional acceptance. And for many, a place they call their last home. My mission is simple: to provide kindness and the best quality of life for vulnerable people in their final days. I might still be young, but in my 20-year journey, I've witnessed the amazing impact of my staff, caregivers, and volunteers that has resonated in my patients' lives, their families, and friends. I felt the smiles and gratitude of my patients and the desire of my staff and volunteers to make a difference in their lives through relieving pain, helping with daily activities and personal care, taking the time to interact and listen, and allowing them to share their emotions about their lives to help them feel valued. I've also seen how the stories of my patients have enriched the lives of those who care for them. I look back with admiration for everyone who has helped me give my residents a safe and welcoming place to live during the most difficult time of their lives. I'm grateful for all of my patients, past and present, for giving me the privilege of sharing their stories, teaching me about forgiveness, acceptance, and finding peace, allowing me to forge bonds and be part of something more than just a building, enriching me with life lessons that I will carry throughout my life. My mission is that no one in our community, no matter their story, deserves to die alone. I am here, dedicated to those who are often forgotten, and to provide the support and mercy that everyone deserves during their final days. We are all worthy.
Okay, I'll hop back on our presentation here.
This is probably my favorite day of all, is when we have the students' graduation.
All right, there we go. Okay, hop back in presenter mode. All right, so Catherine is going to tell you a little bit of how we operate inside of our program.
Thanks, Anne-Marie. So as a nurse coordinator, the first step is to assess our clients and their needs. They have access at the hospice to 24/7 nursing care, and therefore they have quick access to health professional. When we identify their needs, we have medical directives that give us the opportunity to prescribe and initiate treatment. We can also do referrals if we need. For example, I can refer to a physiotherapist or an occupational therapist or imaging if needed. Afterwards, we reassess, reevaluate, and connect with other specialists, hospitals, clinics, or whichever. We also prepare, in some cases, discharge planning, like Anne-Marie said earlier, for non-palliative clients. So we work in collaboration with organization and caseworkers to make sure that the clients go back from where they came from. This model offers always quick access to medical care. It's a nurse-led model program in all inner city health programs also. But we always work in collaboration with physicians. So as you see, we have partnership. We have 3 organizations and we work together. So Ottawa Inner City Health offers the nursing team, RPNs, RNs. We have the manager, physicians, psychiatrics, doctor, and mental health team. We have also a program operation that is Anne-Marie. The Ottawa Mission offers the physical building, the maintenance, spiritual support team. They also offer a Beechwood cemetery. We have partnership. And Care for Health and Community Services offer the staffing. It's a staffing agency that offers the CCWs that are PSW that have extra training and can, for example, give medication. So the services provided, if you see the little circle up top, this is everybody that gravitates around our clients. We have our PNs, we have the nurse coordinator, we have client care workers, that's CCWs. We have our internal medicine, mental health team. We have a mental health nurse team that specialize with inner city health, spiritual care, peer workers, and volunteers. So we do offer basics like any other hospice. That means a room. Most of our rooms are personal rooms. We do have some double rooms. We offer meals, medication, and nursing staff 24/7. We also have a managed alcohol program, safer supply, managed opioid program, and Anne-Marie will talk about them just later on. I'll talk about also money management. So since money is a big trigger for our clients and clients tend to spend it all quickly, we wish to support them. And how does that translate? We can keep their money at the nursing station. And for example, they come and withdraw a small amount daily to help them manage their money and have access throughout the month. So they don't spend it all in 24 or 48 hours. For some clients, it's also translate by they give us money and we help them purchase cigarettes or specific alcohol for the managed alcohol program. For other, it can be by buying cannabis products at the dispensary. We also have peer support. So they can help our clients and they escort them, for example, for their medical appointments. They can also help them with legal matter or even just go to the shopping mall with them. We have harm reduction services. We'll talk about it later. We have a big team of volunteers that come through the mission that help with meals, activities, and just sometimes a good person to talk to and chat. For funeral arrangements and memorials, this is a service that's different from regular hospices because unlike most hospices, our clients do not always have family and to claim their bodies. And we want her to offer dignity to all of her clients. So if there's no family involved, we do claim bodies from the city of Ottawa, and we make sure that our clients get buried. We do have a partnership with Kelly Home Funerals. And if the client wants to be cremated, we also have access to a plot at Beechwood Cemetery. For each of our clients, we do memorials. They're very short and sweet, just a little 30 minutes. And it's a nice way to celebrate our client's life and also their struggles. And we invite family, friends, and staff. And it's a nice way also to grieve. In the main entrance, like you saw in the video, we do have a memorial wall, and with all the name of our clients that have deceased, and every year we update it. So I'll pass on to Anne-Marie.
Okay, so we're going to talk about harm reduction and what that looks like in our hospice. Just wanted to do a quick poll on getting a feel for understanding everybody's, what knowledge you have of harm reduction. So how would you rate your understanding? I know a lot and I have a very high understanding. I know a little, but I want to learn more. I know what it means, but not what it looks like in practice. I do not know much. I don't know what harm reduction is, or other. So I'll give you a minute to vote in that poll.
Okay, so it looks like we have almost everyone answered, so I can end it and I'll share the results here. And if you didn't have a chance to answer, you can write your answer in the chat there as well.
Okay, I know a lot and I have a very high understanding, 5%, 38%, I know a little, but I want to learn more. 28%, I know what it means, but not what it looks like in practice. 19%, I do not know much. 10%, I don't know what harm reduction is. Okay, so that's great. That gives me a really good understanding of where everybody's at. And please write down your questions for the end, and we're super happy to answer them. Okay, I'm going to close that down. All right, so what is harm reduction? So harm reduction is a practice that is centered around reducing the harms that people experience as a result of their drug use. It began as a response to the failure of traditional abstinence-focused treatment. Harm reduction has been practiced informally for a very long time, but it has some more formal movements that began in the 50s and 60s. Kind of across the world, but primarily Europe, United States. So harm reduction is guided by a set of principles that can be applied to any situation. And we apply them to how we build programs, to how we handle issues, and how we treat our clients. So some of the principles that we follow are that we understand that licit and illicit drug use is a part of our world, and we choose to work to minimize its harmful effects instead of ignoring and or condemning them. We understand that drug use is an incredibly complex, multifaceted spectrum that includes all types of drug use, from abstinence, recreational, casual, all the way to severe and problematic use. We understand the power and impact of stigma and how harmful it can be. Not all stigma is intentional, but it exists everywhere, from the micro to macro settings. We know that many of our clients have experienced stigma, shame, and discrimination in many different systems, including health systems, of which we are a part. We believe it's very important to always include the voices of people who use drugs, and that their voice is used in a real way and not in a token way. We understand that people who are most affected by the harms of drug use and the toxic drug supply are the drug using community itself, and they're the ones who have the most knowledge and best understanding on what the solutions are. We do our best to work in a way that affirms that people who use drugs, or our clients, are their own agents of reducing the harms that they experience. We are there to provide the information, tools, support, and empowerment to do so and to make their own decisions. We want to use an approach that is non-coercive and non-judgmental. And finally, and one that we could talk about for a very long time, that is incredibly impactful, is the understanding of the intersectionality of poverty, class, racism, social isolation, trauma, sex-based discrimination, and other social inequalities, and that has impacts on an individual's vulnerability to and capacity for effectively dealing with drug-related harms. It is not lost on us that we are a healthcare organization that works in a system that was predominantly made to benefit white people. There are inherent problematic systemic inequalities that exist in the form of different policies, practices, and even informally in attitudes and beliefs. We have to be aware of this as an organization and actively work towards bettering this system and giving the best healthcare that we can, knowing that information. This community that we serve deserves healthcare, and when you commit to that as an organization, as a fundamental practice, you commit to designing and implementing programs that are designed for the people that are it's going to be serving and the people that are going to use it. And if you're not designing programs that work for them, then you're not doing it right. Mm-hmm. So we still have a lot of work to do, and we're certainly not perfect, but we will continue working towards this goal. So
Anne-Marie, do you think I could interject with a couple of comments that have come up?
Sure. Yeah.
So one of the questions was, how does harm reduction kind of link up with end-of-life decision-making? So I'm imagining this question is about, how do you address, somebody who is dying in the context of continuing to use drugs, and how does the team support that?
Mm-hmm. Yeah. So if I could just contextualize it a little bit. So say you have a client that has been street involved for a very long time in their life, a majority of their life. They've been somebody who has used drugs for a very long time. They're very transient, things like that. It can be very challenging to bring somebody who is out and doing their own thing in the world, doing drugs, struggling with substance use, to bring them into a medical setting that, as much as we want to make it a community type setting, it's still a medical institution. And so it can be really challenging to bring people into that, particularly if they've experienced a lot of medical trauma, institutionalized racism, and things like that. And so we as an organization really need to understand all of those things, understand where they're coming from, understand that healthcare systems may not have worked for them in the past. And so we as a hospice, we can't run our hospice the way that other regular hospices run that maybe I would be successful in, or that would work well for me. We need to create a hospice that is trauma informed, that takes into consideration that people use drugs and have been stigmatized for it. And we're going to get into a lot more examples of how we do that, so I won't focus too much on that. But that's how we kind of connect the harm reduction to the hospice piece, is really just understanding where our clients have come from and trying to make them the most comfortable and the most centered in the decisions that they make and of what happens to them, and trying to give them the best end-of-life care as possible. But I'll get into that a little bit more.
Awesome. So we'll let you keep going before we ask anything more. Thanks.
So how do we incorporate harm reduction at our hospice? So a couple of services that we offer. So one of them is the managed alcohol program. So a couple photos there on the PowerPoint, you'll see there's a big jug of wine with a pour cup beside it and a couple of staff. This photo was taken peak pandemic. But essentially our managed alcohol program is run very similar to that. The bottom photo is the actual brewing rooms. So the Shepherds of Good Hope homeless shelter brews all of our wine for us. We used to do it at a wine bottling place in the South End, but it's far more cost effective to just do it ourselves. So we have a massive brewing room, more than one. And so the managed alcohol program is a program we've run for many years. So its aim is to reduce the harms of chronic alcoholism. We want to reduce the consumption of non-beverage alcohol in our clients. So clients that are drinking hand sanitizer, rubbing alcohol, things like that. So what we do is we bring a client in, we do a nursing assessment, we figure out how much typically are you drinking on the street? What are you drinking? Are you drinking hand sanitizer? Are you drinking sherry? Are you we just want to get an understanding of how much it is that they're drinking in a day. And we bring them into our program and we put them on their own program of prescribed alcohol prescribed by us. So typically it's 5 to 7 ounces of wine every hour for 12 to 14 hours a day. That might sound like a lot, but in the context of what our clients are typically drinking before they come into us, this is a very lower amount of alcohol. And we use wine because it's great to brew, but it's also typically healthier than some other alcohol that is out there. So our managed alcohol is designed to be a very low barrier program. And when our clients need it, we want to be able to admit them to that service right away. So if we had a client admitted to hospice that had some chronic alcohol consumption, we would be able to start them on managed alcohol right away. We know that detox symptoms can happen very fast. And we also know that some people spend, all day, all night trying to get money and trying to get the things they need to get their alcohol. And so it's also a trauma-informed approach. So when we take people off of the street alcohol, the non-beverage alcohol, and put them onto our own alcohol schedule, we're able to give them stability and a sense of control around their alcohol consumption. Anybody's drink schedule or pour schedule is a conversation with the nurse based on the nurse's assessment, based on what the client's wishes are, what their goals are. And so typically when we first bring people in, we start them on a higher dose of alcohol so that we can avoid the detox. So we might start them on 7 ounces of wine and then slowly get down to the 5 ounces of wine every hour. But it really depends on what their goals are. Might be a client that we would do 5 ounces of wine every second hour. It really depends.
We can sorry to interrupt. We also do a loading dose in the morning. So for example, to avoid withdrawal in the morning, the first pour will always be higher, and then we reduce. And we also offer even the special pour. It's diluted alcohol and wine when our clients maybe don't tolerate or they're trying to reduce. So it's customized.
Yeah. We also allow our clients to purchase the alcohol that they want to drink. So maybe we could bargain or negotiate that, they'll have 1 or 2 beers a day or sherry or whatever alcohol they want, and then the rest will be wine. Really just the focus is to reduce as much harm as possible. This is an incredibly successful program. Our data shows drastic reduction in ER visits and EMS calls. So if, for example, if we might have a client that's out drinking on the street most days, they might get you know, if they're intoxicated, they fall asleep, somebody might call EMS because they're concerned about them. So for example, one client, prior to being admitted to the managed alcohol program, on some months had 31 or 32 EMS calls. And then once being on our program, you know, once they stabilized, only having maybe 4 to 6 EMS calls a month. So really much more stability. And when they're in with us and drinking with us, instead of drinking out on the street, we're also able to develop a relationship with them, address their other health issues, get some blood work done, do a workup. So it's really a program that has worked really, really well for us. And it's something that we offer in our hospice for clients when they're reaching end of life. We also offer a safer supply program, which is a very similar concept as the managed alcohol program. It's aimed to reduce the harms associated with illicit opiate use. Most of us know we're in a very intense overdose crisis. We've lost thousands of people in Canada just in the last year from overdose. And so we prescribe prescription opiates, pharmaceutical opiates, so that clients can stop or reduce their illicit fentanyl use. So typically it's a long-acting, slow-release morphine that they're given in the morning, and then combined with short-acting hydromorphone tablets that they can have throughout the day. So very strong data shows decrease in overdose, decrease in what's typically criminalized behavior, improved health and stability, and just much more ability to be stable, to have different goals, to focus on different things other than trying to find what you need to get drugs. And so that program, once we started our Safer Supply program, it was after the overdose crisis had already started for us, and it was such a incredible thing to happen to our community, and something we all remember very fondly, the beginning of that program. And we continue to see so many clients who do really, really well on it. So all right.
Anne-Marie, can I interrupt it for you? Because there's a couple of questions just specifically to that slide. So can you tell us what a low barrier program means?
Mm-hmm. Yeah. So a high barrier program, or just a program with barriers, could be that, you know, there might be a really long waiting list. You might need a bunch of identification or a bunch of forms filled out, or a referral from a doctor that shows that you've had an addiction for a really long time, or you need to pay for it through OW or ODSP, or just like all of these things that you need to do to enter a program, which are normal processes for a lot of programs. But managed alcohol, you come in, we understand that you have chronic alcohol intake, and we want to do something to address that right away. No waiting list, no big form process, no big...
it's the same day. When we admit at the hospice, we'll start it the same day.
Mm-hmm.
And we don't, as the nurse coordinator, I don't even ask the doctor. We just initiate.
It's something we can just start
and
right
we
away.
Reassess the next day. And at any moment, the goal is not to get clients. Sorry, I interrupted you.
No, that's okay. Go ahead.
We don't need, the goal is not to get intoxicated. So at any moment, if a client is intoxicated, we hold pours. Or if the client is using and with polysubstance abuse gets too intoxicated, or because the client is ill, whichever, we're just always reassessing. And it's like a MAR, like for medication. So it's charted and we can follow. And so we really adapt it to the client's need.
Mm-hmm.
So another question related to these services, do you ever have conflicts with clients where perhaps they want more to drink or more of an opiate? And how would you deal with a situation like that?
Absolutely. That's a big part of our lives, for sure. Do you want to take that one as the nurse that has to have those conflicts?
Well, so because also in the palliative context, and we're just aiming that like any other hospice, I always see it that it's all about quality of life and what my clients want. So I will ask them, you know, why do they want to increase their pores, or if they want more opiates, is it pain, and to investigate the cause of the pain. You know, it could be physical pain, it could be emotional, it could be spiritual, it could be, and yeah, we try to find a halfway. Sometimes it will be like, for example, just lately I had a client who came back from a hospitalization, and he wanted to start with a really high dose, and I just explained my concern as a nurse. He explained his concern, and when we went halfway through, and we were very clear, and then I said, you know, today we'll start you at 3 ounces, and tomorrow, if you're not intoxicated, I'll put you back at 5. And we went back at 5. And also, because we build rapport and relationship with our clients, we always have clients that always test our limits and try. And for example, I think with more safer supply, they'll try to increase their doses. So it's to navigate and find the middle, and also not to compromise the relationship that we're working so hard to build, and the trust. I don't know if I answered the question properly.
That's great. Thanks.
So other ways that we incorporate harm reduction at our hospice. So we offer opioid and antagonist therapies, so like methadone or buprenorphine. So those are alternatives to opioids that can still activate the opioid receptors in the brain, and in that sense, they can be good alternatives for some clients. It's not always the best option, but we offer it as one selection of a wider list or menu of options we provide for clients for supporting their substance use needs. And some do pick this option. So we talked about services, like specific services that we offer that are harm reduction. But we also, harm reduction is not just necessarily a service. It's the philosophy in which we talk to our clients, in which we navigate situations with our clients, and how we make decisions. So you know, like what Catherine was saying, we have a discussion, sometimes we negotiate, you know, this is what your needs are, this is what our needs are as healthcare providers, and this is what we can do for you, and how can we meet in the middle. So sometimes it's education to make a different decision, or planting that seed about what it is that we think would be like maybe a less harmful option, or a healthier decision. And maybe they don't make that decision that day, but maybe we can work towards making better decisions. So again, negotiation or compromise to mitigate harm. So for example, I put an example of beer aspiration, which I'll explain. So just a case scenario, we had a client who came to our hospice, and he had dysphagia, which is difficulty swallowing, and he was at high risk for aspiration. He wanted to be on the managed alcohol program, and he didn't want pureed or drinkable food. He wanted his meals, he wanted to eat real food, and he wanted to drink beer. He was someone who had chronic alcohol intake for the majority of his life. And we understand that if we would have said, you know, we can't give you that, it's not safe for you, that he would have left. And he made that very clear to us. So given that, we wanted to make the best decision based on what he was willing to do and based on what we were willing to do. He also had Parkinson's. And so we explained the consequences to him. He had a thorough discussion with the nurse, the doctor. We explained the risks and the consequences of eating real food and drinking with dysphagia, and how that can progress. And he made his own decisions. So we got him an adaptive mug so that he could drink his own drink, and he could eat his own food, and he was extremely happy right up until the end of his life, and he was incredibly appreciative. And we made that work for him, even though we knew that you know, wouldn't have been necessarily the healthiest option. So we focus on the goals of care and we work in partnership with the client. And we also want to use a motivational interviewing and a strengths-based approach. We don't want to be coercive. We don't want to tell the clients what's best for them. We don't want to tell them what to do. They have so many systems and places in their lives that already do that shame them for using drugs and treat them poorly, that we want, especially at the end of their life, we want them to have power and to be able to make decisions and have some control about what is happening for them. And we were able to really give this client a wonderful end of life that we are very proud of, and that he was very proud of. So another way of incorporating harm reduction as a philosophy is so clients who struggle to stay in the hospice. Again, we have clients who have experienced all kinds of institutional trauma, who come from very varied environments. Some people who sleep rough outside year-round, who sleep in shelter and spend the day outside. And so realistically, having somebody who is street involved, used to being out and about and everywhere, and having them come into our hospice, which is a medical institution, and wanting them to stay there all day, every day to get their end of life care is not realistic. And so we might have someone come in and then they disappear for 24 hours or 48 hours. But then they come back and maybe they could stay a little bit longer the next time, and we can develop a relationship with them and find ways to make them comfortable and find ways to make this place work for them. And then maybe they'll still disappear a little bit, but then they'll come back sooner. And then they start to learn that the hospice can be a safe place for them, and that their wishes and their decisions will be respected. So it's always a work in progress. It's always an evolving conversation. It's always hard. It's always messy. It's always complicated. It's never just this black and white thing. And that's kind of the nature of harm reduction and the complexities behind it. But it's an approach that really works for us. Okay, so some of the challenges that we face in running our hospice. So trauma-informed care. I like to think that in a lot of ways we're very good at providing trauma-informed care, but in other ways we still struggle. It can be very difficult to provide trauma-informed care when we're working in a healthcare system that oftentimes does not inherently have trauma-informed practices built into it. Being truly trauma-informed means understanding each individual client's needs, history, relevant information, and we don't always have that. And the client, sometimes we receive clients who are not in great shape and they're not able to voice that, and it takes us a little bit of time to figure out what those needs are, figure out how to be trauma-informed with that specific client, and that's really not always easy, and it's not always best for the client, but sometimes we just have to learn the hard way because we don't have the information that we need. We often have clients that have zero family advocates, zero help with decision making, and zero advanced care planning, zero predetermined wishes or decisions made about what will happen to them or what they want in end of life. And so it can feel very complicated, very daunting to make those decisions for people when we don't have any information. For a lot of our clients, we are their main and only support. And it's a tricky place to be like their family and their support, but also their healthcare provider, especially when we don't have a full, accurate history. So health system gaps is a huge challenge of ours. We talked a little bit before about systemic inequalities that are inherent in medical systems. But we do have a lot of challenges for clients that are maybe really medically unwell, maybe struggling with a big illness, but not necessarily needing a palliative care bed or needing end-of-life care. Maybe what they need is long-term care, but there aren't many long-term care options that people who have been street involved, who have substance use disorder and complex mental health needs, there aren't a lot of options where folks like that would fit into well, and that have spaces like specifically made for them that are safe and trauma informed. So sometimes we really struggle with like finding good places to send our clients when they don't need to be with us. So that can be really, really tricky. We have a lot of challenges with the continuity of care between other systems and us. So, you know, the hospital might receive a client and receive an individual that is, you know, very, very sick, approaching end of life. They might not even know their name. They might not have zero medical history. And, you know, they know that Inner City Health runs a hospice for people who are homeless or street involved. And so they call us to take them. And we don't often get a good picture of even what has happened with them at the hospital before they come to us. So the continuity of care can be really challenging, especially also, we do have a lot of clients that leave AMA from hospital and they don't necessarily fit that well in hospital systems. And so they don't always get good care when they're there. End of life care in housing. So we do have, I think we're six supportive living units. And so, for example, we run a large managed alcohol supportive living unit on Merivale Road called the OICH. We opened it in 2012, and a vast majority of those clients that moved in 2012 are still there today. And when they moved in there, they came directly from shelter. So for a lot of those clients, the OICH is the only place they know as housing, as stability, and we experience a lot of hesitancy from them coming to the hospice when they're reaching end of life. And we have a lot of clients that prefer to do their end of life in their housing. So our programs are staffed 24 hours a day by PSWs, which is great. We have PSW support for giving good care, giving meds, taking care of vitals, monitoring clients, but it's not a hospice, and you know, we don't have hospice equipment at the OICH, but we do have clients that want to die there where they live. They want to be with the staff that are with them every day. They want to be with the community that they live in. So it can be really tricky to have really good procedures and protocols for supporting people, especially in those last few days when the care needs are really high, and getting them the support they need to have a good death, and to have the death that they want and that we want for them. Another issue at the OICH and across many of our shelters and many of our programs is that we have an aging population. We have a lot of baby boomers that are getting older, and especially for folks who have been on the street for a very long time, you know, when they're 60 years old, their body is actually like a 75-year-old. And so at places like the OICH, where people have lived there since 2012, they're getting a lot older now, and their care needs are getting much higher. We have a lot more clients now that need help with pericare and just basic care and basic activities of daily living. So again, the acute care needs, so just not always having a good place. Like we have 7 acute care beds, but we have nearly 500 clients. So, you know, the 7 acute care beds is not enough. And, you know, if we have a bunch of hospice beds open, you know, we might use 1 or 2 of those in the short term, but we also want to keep those beds open for when people need end of life care. So it's tricky. Staffing is always a challenge. I think everybody can understand that burn right now. But in our environment, we have to do so much training when people come to work with us, so that they really understand harm reduction. They really understand trauma-informed care. They really understand how we do things, because we are different than other places. And so for a lot of healthcare places that have high turnover right now, that have staffing needs. It's really hard to constantly keep up with all of those higher training needs for more specialized healthcare that we provide. And of course, the toxic drug supply. So for us in our community, the overdose crisis started for us in February 2017. I remember it like it was yesterday. I remember the very first day we had our very first overdose, and then things just collapsed from then. We've lost so many people, and it really changed our world as an organization, and it really moved so many of our resources into just keeping people alive by reversing overdoses around the corner, in the bathroom, on the street. And it really, because so much of our resources got moved into that, it really took away from like other things we were working on and other services we wanted to improve, because we just all pivoted to supporting people through the toxic drug supply. A couple more challenges that are really prominent and important to us. We're going to explore further in the next slides. Catherine's going to take care of those, but those are providing end-of-life care to people with complex mental health and substance use needs, and cultural challenges of providing end-of-life care to racialized communities or folks who are Indigenous.
Thanks, Anne-Marie.
Catherine, sorry, I'm going to interrupt because there's a few kind of logistical questions about the hospice that I think would probably be a good fit here. So can you tell us about the admission process or the criteria?
Slide about that.
We skipped it.
We skipped it. I was too excited. So yes, how do we do referrals? That's the big question. So me and the manager, we don't want to go the traditional route. We're never probably going to go to a form or anything because it's a case-by-case scenario. We want to make sure that we get these vulnerable clients in. So how does it work? Referrals usually come to me or the manager, and directly from hospitals, social workers. We get from other organizations, and like we said, through the inner city health programs. I also get City of Ottawa. It could be so it's very broad. No one can self-refer. That's probably the only limit. And then we prioritize people that are struggling with homelessness, low income, and our clients that are struggling with drug or alcohol abuse. So those are our main criterias. And we always prioritize for sure end of life. And then palliative, it depends, because palliative, like I've seen that 50% are here. You can be palliative for many years. So then if we block a bed for somebody who's palliative for many years, then if an end of life client needs a bed, then maybe we're stuck. So it's really a case by case, and we take our time and we review charts, and so it's pretty much it.
Do you have a sense of your kind of average length of stay, and would that be different, like for more the folks that have a end of life admission versus?
So like Anne-Marie said, so we're on 3 stories because we're just glued to the general shelter of the Mission. So it's a really old building. So we're on 3 stories, and the 3rd floor where our nursing station is where we have our more acute clients and our end of life clients. So as Anne-Marie said, we can get clients from other programs that, for example, really typical, somebody's panhandling, they get hit by a car, they go to emerge, they get surgery, post-op, they come to us, and then when they're back on their feet, literally, we ship them out. So then they can go back to main shelter or through their housing programs. So they need more one-on-one care, but it's also our unit where we'll have our end-of-life clients that need this pain management, support, repositioning, everything that we do in a regular hospice. Also on our 4th floor, we have more of our clients that are chronic PAL, as we could say, so more long-term. but also these clients that we were expressing that are stuck in the limbo between us and long-term care, and we don't know where to place them. So, and often it happens that our clients are discharged from the hospital and they come in a palliative context to us. And after that, we just fulfill their basic needs and support them where they're at. They get back on their feet. So the PPS of 20 becomes 30 and 40, and then boop, boop, they increase. And then, oh, okay, where do we have to put them? So, but for example, in average, I think it's between 15 to 20 people passing every year. Could be a little bit more, could be less, for example, during the pandemic. And then we have people exactly that we refer, they go back in the community, and when they're ready or closer to end of life and they want to come back to us, they do come back to us. So
great. One more quick question. The situation that you described, Anne-Marie, where the client, you know, wasn't so sure they wanted to be in hospice, that kind of scenario of going away for 24 hours, that kind of thing. Somebody asked, how long would you hold a bed in a situation like that?
good question.
Yeah, so it really depends. I mean, honestly, a lot of the time, like if they're a really street involved individual, like we know them, we know where to find them. You know, I might drive my car down and around where I know they're gonna be hanging out, or you know, Catherine might walk by there and just happen to run into them. But so
it depends. Like for example, one of our latest clients who it was like that, it's a man who's been in the streets for like over maybe 10-20 years, so we knew that he would be harder to get in. And like we said, we have nurse coordinators, for example, at Salvation Army, and we have nurse coordinators that also work at Shepherds of Good Hope, and we're all in contact. So I could be like, hey, did you see Brian today? Like he was admitted to us, but then whoops, after lunch he disappeared, and oh yeah, he's in the street here. Okay, he's all right, perfect. Can you just go chit chat, tell him his bed is available? So we'll keep it. If after a week or two we see that we're going nowhere and there's not an improvement, then we'll probably, like, if we're capable of talking with them and like trying to see why do you don't want to come to the hospice? Do you have fears? Or, you know, we have to explore all of that, then we'll close the bed. But it just takes time, and a lot of our clients, the mental health is not necessarily stabilized, especially if they've been bouncing just in and out of a shelter, so they never have like regular medication. So by coming to the hospice and creating and bonding, and then we have this capacity of stabilizing their mental health, and then they're receiving care, and then this relationship is building. So that's why. So we can't force it. Mm-hmm. We can't force it in 24 hours. So we do take the time.
Mm-hmm.
Thanks, guys.
Okay.
I can launch it here now.
Perfect. Thank you. So the poll question, especially that we have palliative care.
Lots of palliative care people here. It's great.
Yeah, you still got some more coming in here, so I'll just leave it open for a couple more moments.
No worries. I don't know if there's other questions we can answer short or keep them for the end.
I'm trying to go theme wise here, but maybe we could back up a little bit. And I think this is probably broader than just the hospice, but somebody was asking about how the program works with police, paramedics, folks coming with more of a maybe sometimes a bit of a different worldview. And like, are you able to help them to better understand the health needs of this population?
Mm-hmm. So I'm just going to talk about the TED program.
Yeah,
like that.
and then
historically, we've had a wonderful relationship with paramedics. We find like fundamentally, like we value the same things, and you know, there's been like obviously like any partnership or any working together, there's going to be conflicts here and there, but overall we've had a great relationship with them. We do run a TED program through the Shepherds of Good Hope, which is 3 blocks away from the Ottawa Mission. And so that's a targeted engagement and diversion program. And so that's a program where we have a partnership with the Ottawa Paramedic Service. So if they get a 911 call to an individual who's passed out intoxicated, if they respond to an overdose of somebody who's known to be street involved homeless, they can actually divert that person from the hospital directly to us at the TED program, where we have 24-hour nursing. So they transfer care from paramedic to nurse. They hand the client over to us, and we take them into our care, and we, you know, do the post overdose monitoring. We do if they're intoxicated from alcohol, we would do the monitoring while they kind of sleep it off. So we've worked with the paramedics like very closely for a very long time. The police, like certainly, like, you know, there's no way around it. We fundamentally believe different things, but you know, we always are willing to sit at the table with each other. You know, we opened a supervised consumption site in 2017 that you know, we have a legal Health Canada exemption that allows clients to legally be in the possession of illegal drugs within the 4 walls of our consumption site. And a lot of police officers had a really hard time with that, and understandably, right? Like, they enforce the law, they, you know, have these things they have to follow, they, you know, arrest people for possession and things like that. And now all of a sudden there's this rule where, you know, they're allowed to be in the possession of drugs in this space. And so, you know, there's definitely some tense moments, some tense exchanges, some tense conversations around then, tense conversations since then about different things. But overall, because we've been around for so long, Ottawa Police knows that inner city is it for healthcare for people who are homeless. And a lot of them, especially the block cops, know you know, they know that they can drop people off to us. And so we have a really good relationship with some police officers. Yeah, there's some definite inherent issues there in terms of, you know, different beliefs and values, but we have to do our best to make it work, because they're not going anywhere, we're not going anywhere. So might as well sit at the table and see what we can, what agreement or negotiation we can come to together. Doesn't always go well, but sometimes it goes great. So you never really know.
Yeah, and at the hospice, exactly, it's case by case. And sometimes we do have people, when they receive a phone call, for example, and paramedics have to get someone from us, there's prejudice because they're going in a shelter and they're getting someone. So, and as we have to say, as a nurse, I have to report that my client was using prior to, for whichever situation or help situation I want to send my client to the hospital. So when people are judging, I just go back to my assessments and everything. And then if we have a moment to educate, then we'll take the moment. If we don't have a time to educate, then we'll just forget about it, because, you know, the list of tasks to do in a day are big, but it's a lot of that. It's misunderstanding and education. So as advocates for my clients, I always do, and we do it with everybody in the health system on a daily basis. So
we can help our clients submit complaints if they want to help voice their concerns, advocate for themselves. It's really based on what the client wants.
Yeah, so I don't know if did we see the poll results at one point?
I can share them here.
The questions are very great, very stimulating.
Yeah.
Thanks, everybody.
Keep them coming.
And I do have a few additional things that I'll share once we hear about the poll results.
Okay, so pain is the biggest one, followed with family. Yes, mental health, substance use 13%, respecting wishes or choices 16%, and other, I don't know if there's some comment.
Oh, I can give you a few of the others there. So issues with non-compliance, people not returning calls or not having the ability to return calls, navigating the healthcare system, staffing capacity issues, issues with existential or total pain, language barriers, lack of access to primary care providers, challenges with communication between different healthcare organizations, and then clients who also have dementia.
Yes.
Okay.
I think everybody can relate in the palliative world with all those comments. Yes, so providing care when overwhelming substance use disorder means that we have to navigate managing their pain due to their terminal illness, but also we do not want our clients to go in withdrawal when they have substance abuse. Client with terminal illness, they're like any other clients with terminal illness in the hospice. So they are grieving like any other palliative client, grieving their past, the loss of their mobility, autonomy, like somebody said, it's the total pain. Our clients are street involved. They're used to the shelter system, to booking in and out. And like I said, and Anne-Marie said earlier, having a stable roof. It takes a lot of time, and like we said, our admissions are not done in one day. Just for example, like maybe, you know, people think that they would be so happy to come to a calm and soothing environment, but when you're used to noise, to mistrust, it's a lot to adapt. So they need to acclimatize to their new environment. Trauma, our clients have an institutional, physical, sexual, emotional trauma. Therefore, our admissions are very slow. We do not bombard our clients with questions. We try to do an admission over a week. It's not really like in the hospital system. We just take our time, and we need to build this rapport and this relationship so it can last. The mental health is not always stable upon admission, and we have to navigate and see what the client's goals are, their goals of care, and what are their wishes, and therefore we can put things in places. And the system fails them. Health, family, religion. Our clients have suffered prejudice in the health system, conflict with their families. They have been abandoned in many ways by people, by systems. So it's really hard to build relationship and collaborate when they come to us with a really heavy past. So this is and harm reduction helps us. So we will go through a couple of case scenarios, and maybe it's gonna help people to see a little bit what we do. So we just want to talk about Indigenous communities. We do have Inuit, Métis, and First Nation clients that come to our hospice. So we adapt space for rituals. For example, if clients want to smudge, we have to organize and make sure that our smoke detectors are off. And at the hospice, they're very sensitive. So that means we need to inform the fire department, and then we can put things in place. Returning to the land after death, we do have some clients that are Inuit and have been in Ottawa for a very, very long period of time. So they do have like street family, but when it's time to claiming a body, and like I said earlier, a lot of our clients don't necessarily have family, and we become their family. So when we're in the process of helping them and claiming the body, we need to identify really a blood relative. So we sometimes need to work with Inuit associations or try to help and navigate to make sure that we respect those wishes so that people can go back to their land. Understanding different beliefs surrounding drug use. Sometimes some spiritual healers do not want to engage with the clients that are using drug or alcohol, since it doesn't respect their traditional values. So therefore we have to collaborate with people that do believe in harm reduction and spiritual beliefs, and then we can achieve adapted and culturally competent care. Different understanding of medicines. So regular medicines we use in the Western medical system is different from the Indigenous traditional medicine, and we always work to make that available for them as needed. and institutional trauma, pardon me. We have clients that come from residential schools and systemic racism, so we have to take that in consideration. And we always try to refer to expert when needed, connecting with associations or people from the community to offer appropriate care. So for a case of trauma, we have clients that have different types of trauma that come to us: personal care, trust, gender, institutional trauma. Medical trauma, for example, we have a lot of clients that have experienced, and they also have some clients with medical trauma. So we have a lot of clients that have experienced sexual trauma in their lives. Therefore, when we have to be like very vigilant and careful when we're doing, for example, personal care, peri-care, and we have to adapt our care plans and to make sure that we respect their clients' wishes and dignity. So sometimes it can be that we don't allow the opposite sex to perform peri-care to respect their trauma. A lot of our clients also have trauma around bathrooms because they've been abused, they've seen violence, and therefore we really have to find a way to support them and during their personal hygiene. So we offer different options. It could be just using a basin, even just bathing in the sink in the public kitchen, or whichever, just to make sure that our clients are comfortable. And even if client refuse care, like people are saying, adherent to treatment, even it's not just medication for us, it's also just basic hygiene. A lot of clients are not necessarily adherent, so we have to find a way to navigate that and find a middle. Yeah. As for medical trauma, we also try to avoid recreating the hospital setting like any other hospice, but we really have to make sure with their clients that they can accomplish their daily activities. If they want to use drug or alcohol, to make sure that it's safe and it's available. And we also still offer the support for medical symptom management and spiritual support. For substance use disorder, for example, we had a client that came to us not too long ago with end-stage liver cirrhosis. He was an IV drug user, but also diagnosed with autism. So he was facing high needs and opioids. He was suffering from hyperalgia, but also hypersensitivity. And he had a lot of trauma in his past hospitalization, and his wishes were not to die in a hospital. So I got the phone call from the emerge doctor, and she was like, the only thing I can do is send him to you. And I think this is the limit of my capacity. So we admitted him that same day. And yeah, so after getting his pain under control, we just tried to recreate a cozy environment and listening to his mother, and we just reorganized the room, and they just spend their time together and cuddle, and just to make it like it was at home, because initially she wanted to palliate at home, but she had this limit, emotional limit, and she didn't have the capacity. And so we helped her and we helped him, and it was just very beautiful, and he had a beautiful death with us. With alcohol use, so we always try, like Anne-Marie said earlier, we offer MAP as soon as possible, and we also make it available until the last minute. If our clients become NPO and then we think that they're still at high risk of getting in withdrawal, then we'll make sure that they have the medication available. And also substitute choices for clients. We do have a program where there's a cannabis substitution program. So that's a program where a pour can be switched over for a joint. So if a client comes and was already on the substitution, we will continue to offer it. Also, we can explore different alternatives such as edibles or oils or spray, especially towards end of life. And those are products with THC, CBD. And we just see what the client requests are and his needs, and then we collaborate and offer these options. And we also experience challenges for our clients that use drugs. There's a lot of rituals, and it's a community. So for them to transfer from their ritual and the friends and how they use in the streets, and then to come to the hospice where we use more medicalized drugs, and it's like, you know, so it's, for them there's a big gap, and sometimes it's not interesting, and it's a barrier to offer care. And also something that we didn't spoke earlier, but for example, for our fentanyl users, if like clients are smoking instead of injecting, it's hard to recreate that in a palliative setting. So these are challenges that we experience with our clients, and we want to work towards to give better care. So yes, we'll continue with culturally competent care. So culture is a way of life. There's belief, institutions, value, languages, religion, food, and so much more. Our clients have many intersecting identity and different beliefs. They have different identities, and they have different living forms. So like we said, independent housing, streets, sleeping rough, shelters, and they come to us. They also have different beliefs in surrounding around drug use and mental health care. And yeah, as an organization, we believe in harm reduction, but we also understand that other beliefs exist, and we make space for that, respect and trust for those beliefs to exist within our programs. And the biggest fundamental belief in harm reduction is to meet people where they're at and to work with them from there. So how does that translate in a daily, day-to-day at the hospice? It's patient-centered care, building relationship. Like mentioned previously, we do take time, patience to create and connect with our clients. Starting from admission, every step can be very slow. We're meeting the clients where they are. We offer them medication or not, harm reduction, and we review goals of care, and we define what is quality of life for them and how to achieve it. We ask experts. So we recently had Dr. Hamzi Mohamed, who was a consultant and expert, who came and gave us some training on providing care to Muslim individuals. We just also completed our TRC training. And next month, we will have an Indigenous leader coming to the hospice to do an assessment and how to provide end-of-life care to Indigenous clients. She will be providing us with recommendations, which we hope to implement. And we provide tools and supplies for ceremonies that are available to clients at all times. Also, on a monthly basis, we offer country food. So country food is, we offer Inuit and First Nation food every month. So it's we get meat that comes from the north. So generally it would be Arctic chard or whale, and also a stew like caribou or geese or whichever. So that's a nice way also to connect with our clients.
So in closing, we wanted to end with some positives. Talking about the context of our realities can feel very dark and daunting, but we do have hope for the future. Despite all of our challenges and systemic issues, we do have some incredibly strong and resilient clients. We do give a lot of clients dignified deaths on their terms. This is not dissimilar from other hospices. We do find ways to make the system work for us. We do get to see moments of peace and happiness in our clients, and we will keep working to improve things, and we have some goals. We want to increase access to safer supply and hopefully start a safer stimulant program. We continue to lose so many people to overdose, and we see the way that safer supply has changed our clients' lives. And so we'll continue to work to expand it. We want to continue to improve trauma-informed care and building it more permanently and foundationally into the services that we provide. This includes better education for our staff, centering our clients more in everything that we do, and finding ways to make our clients more comfortable. We want to improve pain management for clients who use opiates. We see how many of our clients do not fit into regular health systems like long-term care homes or hospital settings. We want to continue to create environments for people with chronic substance use disorder that is safe and help others create that too. We hope to continue educating others, including our own staff, and supporting other organizations who want to create space for people who use drugs too. We want to continue to build culturally competent care practices by collaborating with equity-seeking communities that are impacted by the services we provide. We want to basically just make the best hospice and the best end-of-life experience for all of our clients.
So thank you very much. And if you have any questions, now I think it's the time to ask them. And we left our emails. If you have other questions and you want to follow up, please feel free.
And I have still more. You're not off the hook yet.
Perfect.
I'm just trying to think of what the best order makes. First of all, I want to say, in the comments, and you'll get the chance to take a peek at them when folks leave. But, a lot of people have been moved by what you've shared and the services that you provide and the difference that you make into people's lives. So kudos to both of you and the teams that you work with. A question, have you had any clients who have chosen to have medical assistance in dying?
Yes. So like we said earlier, we partnership with Mission, Care for, and Inner City Health. Mission has a Christian background. I'm not sure, sorry. So therefore, it cannot be performed on our site, but in the past, we have clients that have requested made and were eligible. So what happens, like any other hospice across Canada that don't offer it on site, we support the client until the last moment and coordinate the care so it can happen in the hospital setting.
Thanks.
Does that answer your question?
Yeah, that's great. Somebody asked about, how could we spread this approach, a harm reduction approach, to other settings? And I get from your presentation, there's a lot that you're doing that's very specific to, because you're a different setting, you're not part of what we consider a traditional healthcare provider setting. But what would be your advice? It's come up a lot in the chat about how we need to look at integrating a harm reduction approach in long-term care. So if you were to think about a couple key messages for folks that are working in long-term care or acute care about how they could, bundle up your approach and try to spread it a bit where they're working.
Yeah, I mean, I got a lot of things to say about this. So I think that, a lot of what we do, a lot of harm reduction, it's not black and white. It's everything is in the gray area. There's no easy answer. There's no easy definition to pretty much anything that we do. And that inherently makes it more resource intensive, brings up more ethical dilemmas, makes it more complicated. And so typically a lot of healthcare spaces are just like, we cannot do this, like, nope, like, and I think as, the toxic drug supply continues to worsen and we see like further erosion in people's mental health and physical health, there's a lot of big conversations happening about the social disorder and the byward market downtown. And so people are further having these like stereotypical and stigmatizing views of people who use drugs, and really struggle to want to include people who use drugs in their own service provision. And, oh, we don't want that here. We don't want those behaviors. We don't want this. But fundamentally, you're excluding, you're othering people that deserve services. So really, I think if you're a place that wants to include harm reduction, You need to reach out to people like us that can tell you how to do it, and to have leaders in your organizations that can champion this stuff and that can have those hard conversations and bring people who aren't good with change, don't want to do it, are uncomfortable with it, strong leaders that can bring them over to the other side. We've had many organizations internationally come and tour our hospice, tour our managed alcohol program, because they want to see how we do it. We've had communities from up north that, they're dabbling in wanting to do this kind of work. So they want to come and visit. They want to physically see how it's done. They want to look at our protocols, at our policies, at our guidelines. They want to understand statistics, and we're happy to share and support anybody in doing that. And obviously we can't support hundreds and hundreds of organizations in doing it, but there's so many resources out there that teach people about harm reduction, give webinars. And so there's so many ways to learn how to do it and to train your staff and to have those conversations. But it is messy and it is hard, but it's certainly worth it. And we would encourage anybody who wanted to start somewhere, to try to educate yourselves and take some steps. And then a year from now, you'll be further than where you were today.
Thanks, Anne-Marie. Couple of kind of specific clinical questions. Who pays for cannabis products that aren't covered by?
Thanks.
Who's gonna answer this one?
So
it depends.
Yeah, it depends. We would pay for some of it out of our operational budget. We are also working on a research project right now, which is that substitution project that Catherine was talking about. We have a budget for clients who don't have coverage for medication. If maybe their ODS, their disability support, or their Ontario Works, or what's typically called welfare support, has stopped because they didn't do their paperwork or they didn't something. Like, we have a budget to cover things until we can get that sorted out. And that's including paying for medications that aren't covered by the Ontario Drug Benefit Plan, that aren't covered by their any other type of insurance they might have. So we will buy cannabis if we need to. Typically we don't need to buy a ton of it. There's other ways that we can get it that are funded, but we pay for it sometimes, or the clients will pay for it out of their own money.
And then another one was, do you have any examples of replacement stimulants? It was a while ago, the question, but I hope I'm incorporating it okay.
Yeah, so replacement stimulants could be, so I am not an expert on this. So I'm not the one to be speaking on it, but there actually was a recent report. So our Safer Supply program is funded by SUOP, and within that, Patrick O'Byrne and Marlene Haynes through Ottawa U do the research and data analysis of Safer Supply, and they actually just released a report that was on safer stimulants, and so that would be a really good resource to look at. But safer stimulants could be things that are typically for ADHD, so could be like Vyvanse, Ritalin, like things like that. In high doses, but I'm really not an expert on the topic, so I don't really want to say much more than that.
And right now we don't have clients on it in our program. But if we have, and also because with our programs right now, we're not running it and prescribing it, but other clients could have access to safer stimulants with another doctor in the community and come to us. So we will prescribe our medication. But then, or we can take over or switch, or depending.
Yeah.
So, yeah.
Coming back to the cannabis, do you use much Nabilone, which is covered by?
Right now, the clients I have at the hospice, so if people have been cannabis users in their daily activities, recreational, most of them tend to not feel the effects of Nabilone and do not like it. For some clients, it could be wonderful for pain or appetite or any side effects. But then, yeah, so we use that, but also sometimes if it doesn't work, that's when we propose other options. I have a client right now that we use THC CBD oil as a long acting, and then we offer it and increase it with her needs. And also she uses joint as a short acting, and yeah, so, and it's very nice and we see some effects, so we're following that, and hopefully that's one of my goals, is to have more of this option for our clients that are not using opioids, as a nice alternative for pain management and palliative care, and also anxiety and different types of pain. So yeah, and all these side effects. So yeah.
So earlier you were talking about some of the challenges with kind of lack of family members, and you know, I would imagine that's quite common. So could you just comment on how common it is that somebody wouldn't have a family advocate? And then what do you do in terms of, you know, if the client is no longer able to make decisions for themselves, you know, if they don't have an identified substitute decision maker, what would you do in situations like that?
So it depends on it. Sorry, I'm
No,
so it depends
you.
on a lot of cases. So I would say at the hospice, unfortunately, a big 99.9 do not have family. Like they maybe have family, but at one point, you know, it exploded or people cut the bridges. And like we said, we're not there to judge. There's mental health, there's substance abuse and all that. So depending upon arrival, if the client is still verbal and has the capacity of decision making, then we'll sit with them and, you know, slowly do these talks and see what he wants. Like we said, about funeral arrangements, about even talking through of memorials. And that's when the multidisciplinary approach, as in spiritual care, is involved, the nurses are involved, CCWs, everybody that connect. And because our clients also have a lot of mistrust, sometimes even the hard conversation I have to go through another person, or even if our physician comes in, he can't have those conversations, and so we'll really tag team. Some cases we need PG&T with our clients, so it's very elaborate and it's case by case. That's why we do talk about death. We do talk about all these conversations, because we want to make sure that we respect their wishes, because we are the one providing the care, but also being their advocate, and to make sure it reflects what they want. For sure, maybe we have some cases that clients really transfer in their end of life and like not a lot of capacity of communicating. But luckily, because our organization has been there for a very long time, I can also call my colleagues, or we have nurses that have been here and working with our clients for 10 or 20 years. So I could be like, hey, do you know this client? And then they can tell us really important information. Or if they were in the housing program, I can try to connect with staff or somebody that knows them really well. So it's just like we try to get as much as we can information, so then we can respect their.
And if they've been in our other programs, then a lot of that work would have already been done. Like if they're in a supportive living unit, then we've had those conversations as soon as we can. But sometimes some clients won't have them at all. So
and also family sometimes reappears after the person has passed away for a different reason. Sometimes it's legal, sometimes it's because of money, sometimes it's or they just want to reconnect, or they realize that maybe, hey, they overheard that somebody in their family had passed. And that's the nice thing about offering them dying with dignity and having the chance of burying them, and also having a place to commemorate them through the plates, is people sometimes will call back and be like, oh, I overheard my dad passed here. And then we can look through and be like, yes, he's buried here, you can go. And so it also helps, you know, when people are ready to reconnect with their siblings. So it's very important.
I think I have 2 more questions, unless something else comes up. What would be the youngest client you guys would have cared for? Somebody was asking if you provide care for teens or youth.
You have to be over 18 to stay in the shelter, and so we would take anybody who is 18 and older. I can't recall a time Oh, no, actually, no, I can recall a few times where we've taken early 20s people who were very, very sick, and we took them through. I don't know if you were.
So since I've been here for 8 months, the youngest client was 31, 45. Now, yeah, I think the average is like in the 40s to 60s.
Yeah.
When we have clients going in the 80s, they're very old.
Yeah.
But yeah, so unfortunately we do see very young clients.
What are the things that you do to take care of yourselves in the context of the challenges that you face day to day and each other as a team?
Oh, I live in the forest, so that's my big secret. So I connect to nature in a daily life. That's a good thing. But I think also, and then I'll marry, is because we're doing such particular work, our inner city health organization is very alternative. So we have so much place to be unique in our care and in our person and as a nurse. So, and we have so much support throughout the team because we are doing this very complex jobs with a very complex community. So, and a lot of dark humor, I think is also a big
I think all you healthcare providers here know the dark humor. It's just a part of who we are now. Yeah, so
that's how I cope. But I do love my job and I do love my clients. That's so for me it seems very dark when we present to other people, but I enjoy every moment, and I feel very privileged to work with them.
I've worked here for almost 14 years now, and I think I've loved every day of it. There's definitely some horrible realities and depressing realities and so many like awful things that you're exposed to, but when you get to be a part of a community that's actively working to be different than the standard system, to help people fit in, to give people things and meet their needs that they've never had met before, it's a really beautiful thing to be a part of. It doesn't mean it's not hard and that I haven't had moments of burnout, and but I think like establishing your self-care stuff and your good supports and having good supports around you is what can help sustain you. And I agree that, like, you know, a lot of us don't have, like, talking to my childhood friends about this work and things like that, like they don't, they're not a part of this world, so they don't understand it. So a lot of us rely on each other and support each other and do what we can when, if I'm not doing well and Catherine needs to carry me for a little while, and then I do the same for her. But other than that, I have a dog. Some of you may have seen him in my bio picture. We got headshots done here at Inner City, and I demanded to have him in there with me. I just try and fill the time that I am not here at work with things that fill me with joy and bring care and happiness into my life, because we can't all just work all the time and be in a negative place all the time and be exposed to negative things all the time. We have to balance it with positivity, and we have to balance it with things that fill us up, so that we can be here and we can be the best versions of ourselves. It sounds kind of cheesy, but it's true. And I learned things the hard way, so I know that from experience. So
Well, Anne-Marie and Catherine, I want to thank you so much. There's just one more there that came up. Can we we'll do one more. Do you have any communication advice for how healthcare professionals can interact, communicate with, and help people who are actively using stimulants and feeling the euphoric effects? It can be difficult for healthcare workers who have little training on this.
So sorry, talking to a client like in the moment when they're high on stimulants?
Yeah. And they're hyperactive, agitated, paranoid, that kind of thing.
So I'm gonna let Catherine answer that one in a second, but my experience, I think that you know, it can be very challenging to communicate with people when they're really high. You know, stimulants, their eyes are big, they're, you know, they're bopping around all over the place. It can feel really hard to communicate with them, and it might feel like they're not very like present in the conversation and you know, focusing on you and what you're saying and hearing what you're saying. But I think it's really important to understand that they know when they're being spoken down to and they're being judged, when people are assuming things that they're thinking or that they're doing, and they're actually very aware and have very good attention to detail of what's going on. I just do my best to speak simple. I'm not going to try and have a complicated conversation with somebody when they're that high. I still am always just like very respectful. I don't assume anything. And if I need to talk to them about something important, I just have like a friendly chat with them and invite them to come back a little bit later, like maybe when they're not so high. But really, I think it's just about like meeting them where they're at in that moment. They're really high, probably too high to have a, you know, serious good conversation with you. But you can still take that as a moment to connect with them, to make them feel important and to make them feel listened to, because they will remember that. Maybe not every part of it because they're high, but I think that people think that, oh, he's too high to even notice me or how I'm talking, but they really typically do. And they remember how you made them feel when you were talking to them. I don't know if you have anything else to add to that.
No, but like Anne-Marie says, is our clients, like, because they're so used to being victim of prejudice, they have this sixth sense and they know exactly when you're trying not to be authentic. So honestly, be yourself, and the client will know that. So you just engage. And I do not switch my approach if somebody is using opioids or alcohol, or just if maybe people have aggressive behaviors or conflictual, then maybe this will be different. But if somebody is high or using any substance, I think it's just to be honest and to see and to talk. And like Anne-Marie said, short and sweet, and then just to be there and acknowledge. And also, if you're a healthcare provider, to just express that you are there to help them and to support them. And so
thanks so much. So you've had a real mix of real great information about your program. You've shown from your heart the love that you have for your clients and your work, and you know, really given us a good sense of the program and the important work that you do. And so on behalf of everybody who's been here tonight in the Champlain Hospice Palliative Care Program, I want to thank you both very much. Nobody sign off because Carl's got his last minute logistics that he has to share with everybody.
And I hope you do have a chance to read through the chat as well. I can open it a little bit for you, but there's lots of gratitude and thank you and very kind comments.
Thank you, everybody. Really appreciate everybody coming and appreciate the opportunity to share what we do and how we do it. And please take note of our emails if you have questions or like anything. Like we're here to help. Yeah.